What's up, rookies? Welcome to another snippet on what pharmacists do. Here we showcase what pharmacists do and explore inspiring pharmacy career paths. I am really excited about this really cool pharmacist-led program that we're going to talk about today. And I'm going to have, for the second time on the show, Dr. Clipper Young. I'm going to let you introduce yourself in a little bit, Dr. Young, because you got so many letters after your name. It's ridiculous. PharmD, MPH, BCGP. I'm just going to let you go over that later in a few seconds. And his pharmacy resident, Dr. Shirley Wong, whom I've known for a really, really long time. And we just reconnected today after a really long time. So it's going to be a little bit different today, a different format. They're going to talk about their pharmacist-led, really unique pharmacist-led chronic disease and medication therapy management delivered beyond the clinics to patients in their homes. So this is a really cool program. They're going to have a little PowerPoint presentation to share with us, and then we're going to go over some discussion around that. And I'm really excited. So Shirley, go ahead and show us what you got. Pharm2Home initiative.
All right. Thank you, Dr. Wabo, for allowing me to come back to your platform again. And
Yes.
It was a pleasure last time. And then now we bring something more to continuing what I discussed a little bit last time.
Yes.
So this program was initiated in 2020, right before the pandemic. And then we ran into the pandemic. So a lot of the data that we are about to show you, we actually lived really through the pandemic, but we survived.
Yes.
So now we have a picture to share with the world a little bit. So and this is really, as Dr. Wabo mentioned, so this is a chronic disease management and medication therapy management that we deliver to their home and also through telehealth. Next slide, please. So this is us. So I will make it short. So I'm Clipper Young, and I'm a Toro grad. I'm Toro all the way. So
all the way, baby.
From a student to post-grad training to now I'm an associate professor at the College of Medicine. And I'll let Dr. Wong introduce herself.
Hi, everyone. I'm so excited. Yes, it's great to reconnect with Dr. Wabo. It's been a couple years now. So I'm a UOP pharmacy grad back in 2021, and that's how I met Dr. Wabo. Also, like when I was a technician to now working as an intern at the pharmacy.
Yeah.
Yes.
You did a rotation with us too at my hospital.
Correct. And then now I'm doing my second year of pharmacy residency with the Pharm2Home initiative and Toro University of California. So I'm very excited to share this initiative with everyone.
Awesome.
So the story here, it's a small world. So
it is a small world.
To everybody around you, you don't know what point in life that you come to meet these people again.
Yes. Absolutely. Yes. Pharmacy truly is a small world.
I know, I didn't believe it in school, but after working in the workforce, I'm like, this is definitely a small world. Yeah. And now I tell all the other students that I work with.
Yep.
So next slide, please.
All right.
So I will be doing the overview of the program, and then Dr. Wong will get into our report card in a bit. Okay. So since the start of the Pharm2Home in 2020, we have grown a little bit. So we start, as of now, we have 2 arms. So as you can see from the slide, we have the clinic arm and we have the community health arm. So what does that mean, the clinic arm? So the clinic arm, exclusively, we only recruit patients from Solano County Family Health Services. And there are 3 campuses or 3 clinics in Vallejo, Fairfield, and Vacaville. So, and then the patients are recruited from the primary care providers as well as diabetologists. You might have heard one of them from the last
Dr.
Shurbrook. Yes. And also Dr. Matt. So they are the one referring many patients with diabetes to us. But we don't just do diabetes though. So I would like to mention the 6 main disease states that we help manage. So diabetes, when I say diabetes, is all sorts of diabetes. So type 2, type 1 atypical diabetes, heart failure, CKD, hypertension, yep, and then asthma and COPD.
Yeah.
So, but
Wow.
the problem with this is very quickly we realize that it's a closed system. So we are not able to truly help as many people as we want unless that they seek help at the county clinic. So,
Yeah.
and then very quickly with Dr. Wong joining us, we expand a little bit to the community. That's why we created a community arm in the middle. So we have been going to senior facilities that the seniors, they live there. So we bring medication therapy managements to where they live as close as possible. That's technically their home as well. But then we are not doing as much compared to the clinic arm because we are not their healthcare providers. So we can only make recommendations, and we encourage our participants to bring our recommendations to their PCPs, to their healthcare providers, so that the recommendations hopefully can be implemented. But then still, as you imagine, we're only going to specific locations where that is not a true open access. It's more open than clinic arm, but not as open. So the third arm, as you see at the bottom, that we have this Pharm2 library, actually is one of our students' ideas. That she was saying that, well, I'm very passionate in education. Is there anything that we can do? Then say, sure, let's build on top of the platform that we have. And now we're in the process of hopefully bringing in chronic disease education to the library to start with, and that we're hoping that that will be the most open platform. But we're not doing any intervention, that we only disseminate information about chronic disease management.
Gotcha.
Okay, so with this platform, let's move on to the next slide. So now let's get to the setup of the clinic. So now you see a house. In the middle, we have patients, and then patients would go to the Solano Clinic, Family Health Services, and they might be spending what 15 minutes or 30 minutes at the clinic, but then they might go back to the clinic every 1 month, 3 months, and 6 months. So that means that there's the black hole of time that they're not in clinic. There's probably no connection unless that the patients call the clinic to ask for help, right? And this is where that we come in, the Pharm2Home would come in to deliver care, to connect with the patients, so that we can get the most up-to-date information and then bring it back to the providers, bring it back to the specialists, and then hopefully we can be the glue to connect all the pieces together. And through delivering home visits and telehealth visits. One thing I would like to mention though, we are not here to replace anybody. We're here to hopefully to add to the big picture, as you can see this structure created by Dr. Wong. She spent so many hours creating this whole picture.
Wow.
Right? And then we are also sharing the clinical notes when after each visit, so that everybody can be on the same page. Okay, so this is a setup for the clinic arm. So next slide, please. So a little bit about the bigger picture. So I might have mentioned earlier, this is a really intersection between clinical care and public health practice with the pharmacy platform. So you might have seen this components. This actually, we use this structure from social determinants of health. So, but we can make a little tweak on it though. So let's start with the graduation cap on the upper left. So one of the goals that we want to really deliver is, well, maybe before I get to that, is what is the overarching theme that we want to do? It's so we have a mission to get to know our patients beyond the diagnoses. Why are we doing that? Because they don't spend enough time in the clinic. So a lot of the things that might have missed when they are in the clinic, not so much that the clinic is not doing the work that they're supposed to do. It's just the time pressure is always there for everybody. Even for us, we have the luxury of time. Maybe people would hate me for saying that, but we have a little bit more time. But doesn't mean that we're able to capture everything. So that's the reason why that we want to spend an hour with the patient if we can. So to get to know them as much as possible, so that we can relay the message back to the PCP, so that when the patient at the PCP's office, then the PCP know a little bit more about the patient to have that shared decision-making process. So, but then going back to the different area components of this slide, so that we want to encourage behavioral changes, because after all, we are focusing on chronic disease management. And then we tell them about what does that mean to have diabetes, or what does that mean to have hypertension. So hopefully they understand and they are more likely to take their medications every day. And then next to the left bottom, so we offer a few things. So we just highlight here. One thing is we recommend because we are pharmacists, so we offer alternatives to get the medications as cheap as possible. Maybe we change from one medication to the next, within the same class or within different class, hopefully get to the same goal of disease management. And also we help patients to increase the access to medical equipment. What does that mean? We can send prescriptions for blood pressure monitor, for glucometer that they didn't even know that's covered under insurance. And then we can help them to bridge that gap. And then on the right, so, and that would be the clinical thing and also the social thing that we also provide to the patient. So we help care of coordinating care. So one thing that Dr. Wong did a lot was she would call specialty clinic, which is not a part of the primary care facility. And then, but usually there's the communication between the two entities is limited. So that means we are also there to make the connection. She was calling to set up specialty care appointments for patients, and then link it back to the primary care providers, so that everybody is on the same page. That's an example. And then for us, what we do is when we see patients on 20 meds, the first thought that would come to mind is how can we help you to lower your burden so that you will not feel super overwhelmed and then you somehow not doing anything to manage your condition. So we have to pre-describe medication so that we can combine some of the medications, or maybe we can somehow discontinue some of them and just not helping patients. And also duplications, that is another example. And also, as I mentioned earlier, we work with physicians, NPs, and also PAs as a team, so that we also deliver care from an interprofessional perspective, which we believe will only enhance care. And then lastly, that would be the social aspect of care. That would be we're hoping to enhance or to implement some of the social connectedness through delivering social activities. We are not there yet. Well, it's all depending on how much funding that we're able to get from our funders. And then, but hopefully, an example that we're trying to do is delivering care to the senior facilities, and then we can play some games with them so that they can not only get information about their health, but also hopefully they feel connected with people around them. So now let's move on to the next section. That would be Dr. Wong.
Yes, and then also wanted to highlight, we did create osteoporosis bingo at a senior facility. So that was pretty cool for them to learn about osteoporosis.
Right there. Yeah.
And then the seniors, I know they love their bingo, so you never want to disturb their bingo sessions.
So cool. So cool.
All right. So I'm really excited to highlight some of the outcomes and also kind of show you some of the demographics and people that we've been serving. So as you can see here, we kind of break it down into a pie chart. We have African American, Caucasian, we have those of mixed races, and then Asian, American, Indian, Alaskan, and then those who didn't specify. And so I think for us in Solon County, this is relatively diverse. I think we can continue to expand in this area, but that's as we continue to get more patients. And then just to specify, everything that I'm explaining here will come from where we started our first patient back in June 2021 up until October of last year.
Okay. And
then this will highlight health insurance coverage, which also will give you a perspective of our community and also kind of their income status. So majority of our participants do have Medi-Cal, and then we do have those that have dual Medicare, Medi-Cal. And so, and you can see here, 88% do have Medi-Cal. And then the rest are either commercial insurance or government, other government insurance.
Okay.
And then these are the people that we serve. So fortunately, we do have a language interpreter line because some patients, we have a lot of patients who do speak Spanish, and that's I feel like language barrier in the healthcare is hard. And so there's always miscommunications or maybe mistranslations that or things that can't be translated in other languages, which makes it difficult. So they're trying to convey their message, but they can't get it across because there's just no other word for it. Yeah. So majority do speak English, Spanish, and then we do have those that speak Vietnamese, Mandarin. We have some Punjabi, and then some other languages that are like smaller dialects. And then, so this is the 6 chronic disease states that Dr. Young had mentioned earlier. So you can see primarily those have diabetes, and then the purple is hypertension. The orange is hyperlipidemia, which I think those are 3 major chronic conditions that go hand in hand. And then 17 of those have chronic kidney disease. And we've been noticing that there are a lot that are undiagnosed chronic kidney disease, which I think pharmacists have an opportunity to actually take a look at the labs and mention to the provider, hey, I think some of these meds may need to be adjusted because of their kidney function. So these are just like mentioned in the chart diagnosed, but we do have those that have not been diagnosed, even though they may have low EGFR or kidney function. And then heart failure, 5 of them, 6 of them have COPD, 5 of them with asthma. And I want to highlight here, 14 of those individuals either had a cardiovascular event, whether it's stroke or MI or some kind of like stent pacemaker in them. And then this just kind of highlights how many patients we have so far. So 122 patients were referred thanks to like the providers at the clinic. And then we had 71 initial visits, meaning we have either visited their home or we call them on the phone or video calls. So we give the patients the options of which one they feel comfortable. Some of them say like, well, it's too early in the morning, I don't want you to see my face yet. So then we'll do a telephone call. And then 12 of them have completed the program, and we've been following them every 3 months and 6 months just to see how they're doing, whether some of the changes that they made during the program was sustainable. And then this is just to showcase kind of like the equipment. I think a lot of the individuals, if you look at the left column on the purple, majority of them when they started do not check their blood pressure or blood sugars at home. So we have 1 that checked their blood pressure, 8 that checked their blood sugar, and then 8 that actually checked as recommended by their diabetes regimen. You can see that once they start, this is at the time that we evaluate them in October, and so they're still part of the program, is 21 individuals started checking their blood pressure, and then we checked them 3 months later, 5 still continue, which are those who have graduated, 2 still check 6 months after the program. And then some of them data were not captured just because we weren't able to reach the participants. And then those who checked their blood sugars, 55 of them, I think if we recall, there were 70 of them that do have diabetes. So I think this was significant improvement for those individuals. And I think this goes back to the original point that they have to understand what their disease state is and why they're checking their sugars. I think oftentimes they feel it's burdensome because they have to poke their finger and not knowing what to do with their numbers. And I think pharmacists in this area have a way to like provide education, whether it's in a community setting or ambulatory care setting. There we go. And then the last is checking it as recommended, if they're on oral agents versus insulin, checking recommendations are different and variable. So then 42 of them do check as recommended. And most of them follow 3 months after and 6 months after. And some of them may have decreased checking because we've had removed some of their medications while they're in the program, which was great. And then this highlights so we were talking about diabetes, majority of our participants do have diabetes. So we just want to showcase improvement in their A1C. This is just one of the ways to, one of the markers we use. So initially we have 57 participants that we did an average A1C of 10.3%. And at follow-up for those 57 participants, an average improvement of 2%, or I think like 1 point something, 2.5. Sorry, 2.5% average reduction.
Wow. That's awesome.
And so then there are some that have not gotten labs done yet, whether they're not due for it yet, just because we usually check either 3, 6, or 1 year, or they just simply haven't gotten it yet. So we only had it captured for 41 participants. So 2.5. Reduction, and then average time kind of varies. I think it really depends on the patient's needs. Some of them have like more needs than others, and some say that, oh, well, after 2-3 months, I think I understand how to manage my conditions better, and I may not need as much support. Some of them might need like more frequent check-ins and or longer duration follow-ups. Okay, and then this is the last, I think, one of the points was that we were trying to help patients increase access to equipment to help them manage their conditions. So I think for like blood pressure, increasing access to their blood pressure monitors. A lot of them don't check at home because they simply don't have one. And then I think Also for technology, I think everybody may or may not be aware, but there's continuous glucose monitoring, which may simplify patients' life. And so we've been helping a lot of patients get on technology. And of course, it's not suitable for everyone. So we ask the patients kind of what they're interested in and whether they feel this could be beneficial. They can try it out. They don't like it, then we, take them back off of it, and they can go back to the traditional finger sticking. So we had 37 participants that we placed on CGM. And then a lot of them do love it. They're like, oh, wow, significant reduction, and they're checking their sugars.
Yeah.
Yeah. And then this is average pain score, which I want to highlight. I think this goes with any disease states. I think it's really difficult to it's very distressful to manage so many conditions. And specifically, there's a scale for diabetes, which is problem areas in diabetes. So we ask them a series of questions and whether they feel it's a problem for them, whether it's managing coping with complications or feeling scared or depressed about having the condition. And so at the time of when we had screened them, there were at the time there was 9.9, the score was 9.9 out of the 20 for the scale. And a score of 8 or higher is indicative that there is some form of diabetes-related distress, and it could be from any factors. And then at time of graduation, there's a decrease. We're not sure about 100% why there's a decrease in the distress, whether it's maybe they are living with it now and they have come to terms that they understand the conditions, or is it just simply knowing what to do from day to day and then making their life simpler? So 8.1 out of 20, and then so that's a 9% reduction. And then we also do check their self-perceived efficacy, meaning how confident does a patient feel in managing their conditions? I think oftentimes we don't ask that enough. And sometimes they may not feel confident, but then they don't necessarily tell you upfront because they might feel scared to mention it. And so we actually ask them a series of questions to kind of gauge where their confidence level are. If you're very confident, or if you're not confident, why do you not feel confident? Is there any areas of improvement? And every visit, we actually ask the patient what their goals are. And so this is our way to kind of change their behavior. We're like, okay, looks like this goal didn't work out. What can we do to, make it happen? And then I think in pharmacy school, we always learn SMART goals. And so this is one way where I get to apply it. What are some of the goals? And please make it SMART. So we teach the patients that.
Yeah. And what was graduation? Again, can you define graduation?
Oh, sorry. Yeah. We haven't found the correct proper term, but we see them as graduation, meaning they've completed the program, whether they felt that they do not need further assistance after the 4 to 6 months.
Okay.
Yeah. So completion of the program, essentially. Or some of them may have moved out of their counties, and so therefore we're unable to continue to serve them.
Okay.
Yeah. So there was a 10% increase in their confidence level, which we think is great. And then we kind of asked them what triggered it, and how did you gain the confidence over this period of time. And then the last thing I want to highlight is hypoglycemia episodes. So of course, those with diabetes, I think oftentimes when they're home and they get scared, which makes sense because your sugars are low, and not knowing how to address it, which I think is great as a pharmacist, that you can educate them on different ways to treat it, or if necessary, please go visit the emergency room because it is significantly low and it's not improving. Yes. And I think something that I've learned over the 2 years is that we always learn the rule of 15, the 15 grams of sugar, and going to a deeper level is actually asking what the patients have available at home. We always tell them, hey, buy some juice or buy some soda, a small can, but then cost is an issue. And that's something that I've realized working with these patients, is that not everybody can have access to those 15 grams of fat, and carbs.
Yeah.
Okay. And that is all about the program itself. We have other details, but probably for another time.
Yeah, this is a great overview of the amazing work. This is and talking about what pharmacists do. That's why Dr. Young thought this would be an amazing thing to present, because when people think about what pharmacists do, people don't think about social connectedness, behavior change, cost lowering, saving money for the healthcare system, access to medical equipment, care coordination. And Dr. Young used the perfect term of being the glue that holds everything together, just being in there to fill in the little gaps, right? Because in the presentation you mentioned, patients have 15 to 30-minute appointment slots every 3 to 6 months, and how you gonna let the patient go home? Okay, you have diabetes, here are your medications. Let's see how you're doing in 3 months. Diabetes and many chronic diseases are conditions where patients need support throughout, in between appointments. And I'm not gonna get mad at you, Dr. Young, for saying pharmacists have time, but that's our training. We are the medication experts, but not only are we medication experts, there's the data that you presented. You looked at an amazing program and you decided to look at how this is impacting, what impact I'm actually having. So by doing this, gathering all this data and doing all this analytics and presenting this to us here and to other conferences, maybe it's going to open doors for other programs or other schools or other hospitals, counties to do the same thing, because it truly works when you get pharmacists involved in such multidisciplinary teams, and really improving A1Cs, improving blood pressure goals, improving medical equipment use, inhaler use, and things like that. So this is like so awesome. The patient doesn't even have to, because transportation is an issue for a lot of these patients, and calling them and going to the home and really, oh man, you guys said getting to know the patient beyond their conditions. They're not just diabetics, they're people. They're people with lives. There are people who consider 15 grams of carbs as, I don't know, rice or pasta, and then and it's such information, basic information for us, but we as pharmacists, I think we have that unique place where we can get in there and connect with these patients on a really late level, person level, and help them with disease management. And you showed the data. Even with such a relatively smaller population group, you can make a huge, huge impact.
Well, one thing I would like to say is, I haven't said it enough, that I really need to thank Dr. Wong for making this possible for patients, because patients who know Dr. Wong, she is the face of Pharm2Home to patients.
Wow.
And when patients, they feel they're in trouble, they call our number. Like their sugar is low or they're depressed. So they're in the hospital at the ED, not feeling what to do, not knowing what's the best, what things will come their way. The first person that they thought of is Dr. Wong, calling, crying, asking for help. Hearing that, I have always, I don't like it when patients call that they're in trouble. I don't like to hear that. But also,
you're there for them.
But exactly. But I'm also glad in a sense that they actually, there's a number that they feel comfortable calling, and there's a person, Dr.
Direct
Wong,
person,
be there to answer their phone call. Probably there's not much that we can do at that point because they're at the ED, but at least that there's a voice that they want to hear. It's a sense of comfort.
Yeah.
That in a strange environment, unpleasant environment, there's a voice that they can hear, that hopefully they can calm them down, so get them through the crisis, and then at home, then Dr. Wong will come back to their life.
Yeah. So true. And when you mentioned bingo and social connectedness, sometimes, because I also get work in a diabetes clinic sometimes you call a patient to go over the blood sugar readings, and you guys end up talking about their granddaughter's birthday. And this is maybe an elderly woman who lives alone, and just having that one person that they can rant about. Okay, my sugars are high today, but it was my grandson's birthday yesterday and we had cake, and but then you listen, and then you can take that opportunity to talk about, okay, sliding scale correction maybe next time. I mean, you can use all these little things to just be there for your patient and educate them, so you're not only taking care of their diabetes, but their anxiety goes down. You guys mentioned anxiety and depression. All that can also affect your quality of life, like your life expectancy. And when we talk about improving health and life expectancy, it's not just the numbers. It's not just the A1C. It's also the person's, state of mind and state of just being, in the world. Shirley, this question is directed to you because you did such an amazing work implementing the program. I know you had Dr. Young and Dr. Shubrook and the whole Pharm2Home team at Turo, mentoring you behind this, but you gathered this data, you dealt personally with the patients, you saw the impact that the program had on them. Can you, and Dr. Young talked a little bit earlier about patients just knowing that, trusting you as a healthcare provider and really being comfortable with reaching out to you in emergency situations and having your voice to guide them into what the next step should be in their care. So what has the Pharm2Home impact being in the community, in your community, which is your community, with all the work that you've done, and as a pharmacy resident and as a pharmacist, how has that work impacted you?
Okay.
It's a lot.
Yeah, it's a lot. Okay,
That is such a loaded question.
It is. I will try my best to answer that. I think first off, probably would like to at least thank Dr. Young and the team for believing in me, because I remember on the first day he was like, "This is your first patient. You're gonna call them. You're gonna set this up." And obviously there's no track record yet of like what the flow is. And I thought to myself, what am I gonna say? What are we asking the patients? What information do I need to make it happen? And I think it's like a trial and error. I think the first couple of times, I think I was very nervous and I was more focused. I think as a student, we're always focused to gather information and not so much the big picture. And I think that's something that I've learned in the last 2 years is big picture is important. The details can come later, and the details will slowly trickle in, and patients will start to open up and share those with you as you have a conversation with them, more so than just like a Q&A, like back and forth. And I think over time it's gone smoother. Sometimes like I think you mentioned, you just talked to a patient granddaughter's birthday. We have that all the time. They call and said, "Oh yeah, this happened on this day," and they just want to share. I think it's nice that they are able to have access. They can even send a text message, like as if they're sending a text message, and we will receive it in our system, and then we would just text back. And so, and I think over the times, I think the personable level as a pharmacist, I think a lot of them were shocked. They're like, "Wait, you're a pharmacist, but why are you coming to my home? And you can do that?" So I think that was like opening eye experience for the patients themselves. And a lot of them do have mobility issues. And so I think you mentioned too, like transportations, and it's really difficult for them to like schedule or even get. Some of them, just simply getting to the car can give them an asthma attack or like a trigger. And so for us to be there to go into their homes, as long as they're comfortable, then they're like, "Oh, this is so much easier," and we can review other medications. I think this goes with all providers and pharmacists. They either pick up at a community location. We don't know what exactly they're taking at home. So being at the house, that we're able to see what's going on. And some of the interesting things, I think storage, I've learned over time. As a student, I didn't think about, but now as a pharmacist, I realize storage is important for some of the medications, especially like insulin or like even our injectables. And we saw our patients leaving it out in room temperature, and they've been doing it for a while. And we're like, "Oh no." So this is a great opportunity for us to like kind of catch up where they're at, and then kind of change that behavior. Make sure you store these in the fridge, and these could be left at room temperature. And then also seeing how they use their inhalers. I think that's something that we teach them and we verbalize, but then until they physically do it, then we realize the challenge behind, like, the coordination is really hard. And then we learn in school too, coordination is really difficult for a lot of them. And so then we can see, okay, inhaler technique needs to be improved. And so I think those are all that we don't have time in a provider setting, because they have 15 minutes to get through it, like an appointment. And so I think, like, I know we have luxury of time. We go to their house, visit them, and sometimes we just chat about nothing. And then that lightens up their mood to actually want to do the finger sticking or do the blood pressure checking. We ask them for a log. And I think through telehealth, I think this is a challenge that many experience, is that, patients like, "Yeah, I forgot to check. I don't have any readings," and they feel really bad about it. But I think on our spectrum, instead of, blaming them like, "Oh, you didn't do this, you didn't do that," we ask them what exactly is causing you to forget, or is there some way that we can help you remember, or is there a particular reason you didn't feel like checking? And some of them just simply say, I didn't want to check. I didn't feel like checking. I don't want to know my numbers, and that's fine.
Yeah.
And I think we try to like slowly educate them at every session. I think like you mentioned, Dr. Alvarez, like little bits at a time. You educate them on their sliding scale while they're telling you a story and make it personable. Eventually they'll start doing it. And I think that's helped me like grow too, to learn how to communicate to the patients, because everybody comes from different backgrounds, and I think there's no one structured way to have a conversation with them. And some of them, now I think I know a lot of their backstories. They like, sometimes they share like 20 years ago, I did this. Oh, this was my job before I retired. And so, and being able to kind of bring up some of the, those items that are personal to them kind of helps the conversation too.
It does. It does. It helps you feel like, okay, you're not just calling me today to yell at me for, about what I ate, or for not checking my sugars, or for forgetting to take my medication, but you really care about what's going on in my life. You're really calling to have a human interaction with me, rather than just my numbers, rather than a number, and makes the patients feel like they're truly seen and valued beyond their diagnosis, getting to know the patient beyond their diagnosis. So what this tells me, Dr. Young, is that pharmacists are highly trained professionals that can be used, that can be incorporated in a multidisciplinary team and fill in the gaps where needed in healthcare. And Pharm2Home is just an amazing model that, if applied to a broader scale, can really, really make a difference as far as chronic disease management and medication therapy management go. What advice do you have, Shirley, to aspiring pharmacy students, pharmacy residents, in how do they find their voice, their path in pharmacy?
Oh my, that's a hard question. I have to think back to what I've done.
You've gone through, PGY too. You have a lot to say.
I would say, as students, is to be proactive, take initiative. If there's a new opportunity to learn something, go for it. Whether you're in any rotations, or like there's healthcare community events, if that's what your passion is, go out there, and that's where you get the experience. And I don't think it just comes to you automatically. So I think once, when I was a student, I remember struggling there, like, oh my God, my preceptor's watching me, I don't know what I'm going to say. And then I think it just comes over time, and sometimes just repetition. And I think a lot of times for me is when I see a patient who's upset, I feel like it doesn't fade me, because I feel like they're not upset at me per se, but it's a situation, and they just have nowhere to like exert that anger or that frustration. And just simply, I think for all the students who get scared, I think as a student, I was scared too. I was like, oh my God, did I do something wrong? And that's our first thought, right? As like human beings. But I think also the first question to ask your patients is, we're here to help you, if you're frustrated about the situation, and obviously like try to empathize with them and say that you understand their situation. I think that always helps alleviate a lot of the, to bring it before it blows up. In a sense, for lack of better words. Be proactive, take initiative, and then also try your best. I think in school, we're like in the books. I think try your best to figure out how you can apply those concepts that you've learned, and ask your mentors, ask your preceptors. They've been through many years, they've been working a lot, and ask them what they've done that worked well for them. And it may not work well for you, but then eventually some of those tips will come back to you when you're like working in the field. So I think ask your preceptors and your mentors. And I would say, if you have time, try to do those extra webinars, like try to like keep up to date on CEs. I think even when I was a student, I would attend some of the CHHP seminars or webinars just to get extra info. They have guideline updates. I think when you're working in the field, it's really hard. As a resident, like I'm sure you're like busy attending patients, publications, research, all of that. And so to try to set extra time aside to kind of get those updates will also help you. And I think last thing is to really understand why we learned that in school, and then that will help you easily apply it to your patients. Because I think we learn the scientific stuff, and then when you try to explain it to a patient in a scientific way, they're like lost, which makes sense, right? So then we're like, how can you explain it into a layman term to a patient, and that will help you apply it later on, and slowly it'll come to you.
Yeah, such great advice. Dr. Young, the mentor, the preceptor, based on what Shirley has said, how much do you agree with that? And any last words about Pharm2Home's unique model and how it projects the pharmacist impact on healthcare?
Yeah. So I would like to answer the question in two levels. So first, it's Pharm2Home as a program. I'm really hoping that we deliver care from a humanistic standpoint, which is one thing that I mentioned for one of the slides. We are not here to yell at people, and we're here to meet where they are at. That means everybody is different. So that means we need to change the approach for every single patient, which is Dr. Wong is very great at. And she would be very patient. And sometimes I think that she's a lot more patient than I am. To truly listen. I think that the number one skill is truly listen. Where are you at? How can I help you? Where do I fit in this picture of your life? So that we can truly make the impactful, just little bit small, but impactful things so that you can move on to the next phase of your disease management. And also, we have to also acknowledge that this is not our condition. This is their condition. What does that mean? That means they get to make all the decisions that they want for their own chronic care management. We're just here to support. We're just here to make recommendations. We're not here to tell them what to do. Who are we to tell them what to do? So that means, and I'm also hoping to have the other, so this is the clinical, the physical, and also the mental health component that we touch a little bit on. We found that in order to be effective, we need to address both at the same time. Like Dr. Wong has really run into walls, patient after patients. Why are we not making improvement in some patients based on their clinical indicators, A1Cs or blood pressures? It's just because they're so overwhelmed and probably they are depressed that we didn't even pick up. Even multiple encounters. That means my advice is let's stop right there. Let's truly go back to ask if the patient has diabetes, and ask about the diabetes distress questions, or ask about the depression question. Just screen. Maybe we need to take another approach. So I would say don't be afraid that we just hit the wall. We just don't see any progression. What do? Just somehow stop and think about what are the other components that could have caused the stop of progression. And then we just have to take a different approach. So, and that applies to many, many different things that we do in life. And also the public health aspect, we need to send the message out there that chronic disease management is very doable, but it takes a lot of time out of patient's life, out of professional's life, but we are here together to help them. So that's what I want to send for the program level, but for the training level, and I'm just amazed every time that when Dr. Wong shared the stories with us, that this is what I heard everything secondhand through her. So, and every time that she tells me about a patient story, I saw that care, that flame inside of her, that she truly cares about every single one of them. Even though it's frustrating in a lot of the situations, but she is there. Even though she's frustrated, but she's there. Stick to it, and then we come together and devise a plan for the patients. And oftentimes, it's probably not the medication plans. It's the social support plans. How can we navigate for the patient so that they can get the care that we cannot provide? But we have to realize there's only so much that we can do as a program. And we need to somehow ask for the outside help, that we are, going back to the term that I use, we are still being the glue that we want to be. And then also I want to train her to be the caring, the humanistic provider that she will go out there when she finished the program to like a flame to somehow impact the people around her, because it has to start somewhere. And I'm hoping to see more health, more pharmacy practitioners are doing more of that. So that we can, it's doable, it's really doable, but it will take time. So hopefully the residents coming after her will continue to have the flame inside of them so that we can spread throughout the patients that we help.
That was going to be my next question. Who's going to take over after this PGY year is over?
We don't know.
Yes,
We don't know.
probably
We're still
the
in
new
the process.
resident.
We're still in the
Okay.
process.
I have like one last advice for students
Yes,
who are
girl.
looking to pharmacy. Yeah. So
Yes.
I would say, I think the trust is never the first day that you talk to your patients.
Woo!
Yeah.
That's
So
true.
you might,
true.
yeah, you might just hit walls all like for months. And so we've had patients who never want to open up and they're just scared
So
to
good.
open up.
Yeah.
And sometimes it's just that one conversation, I don't know, 2 weeks later, somehow they just start telling everything that you wish you had known 2 weeks ago, but that's okay. They eventually opened up. So I think that's what matters. And I think trust is built slowly over time. And I think it's just how we communicate to them
Yes.
to build that trust.
Yes. Yes.
So don't feel bad if you couldn't get anything on the phone call or visit.
Yeah, it takes time. It takes time. And accessibility, pharmacists are really, really accessible. And this is the kind of program that showcases that displays that. So are you accepting volunteers? What if there's a pharmacy student who wants to help participate, or an aspiring pharmacist who wants to shadow? Do you guys do any of that?
Thank you for the question. We don't have the pathway yet. we consider so the reason why that I'm a little hesitant to answer that question, not so much I don't want to, it's because it's patient information. There's a lot of that. It's really patient information that we have the duty to protect.
Yes.
Right? So, but I'm open to the idea of how can we protect patients' information, but at the same time that we allow shadowing opportunity, so that students, we do take students on rotations, but those pharmacists, for example, wanting to see what we do, I'm hoping that we can offer that opportunity. How can we find a balance between that we offer meaningful shadowing experience, but not at the same time that we don't compromise patient information? Yeah.
Pharm2Home, pharmacy services, clinical pharmacy services led, delivered directly to patient's home, going beyond the clinic walls into the patient's home, providing humanistic healthcare to patients in Sonoma County. And as you saw with the data that Dr. Wong presented, having really, really tangible data that shows that it works. It helps people be more comfortable managing their diseases. It improves their numbers. It improves their humanism, their reason for being in the community and having people to connect with. So such an amazing program. If you have any questions for Dr. Wong or for Dr. Young, please don't hesitate to reach out to me here in a comment on YouTube, wherever you're listening. I'll be so happy to connect you with them and answer your question. And if you like the video, please subscribe, comment, tell us what you would like to see in the future as far as content goes. And until the next episode, until the next snippet on what pharmacists do, stay blessed. Thank you, guys. Bye-bye.
Thank you.